Now, we have a treat. Good to see you all. Gordon Coburn here runs a $12 billion company in this space. I want to start off just with sort of a space-age question, because you're the one who knows it all in terms of data. You're consulting with large insurance and healthcare systems on how to make them better. But you also have old people, middle-aged people, millennials, sub-millennials. And I'm really interested in, if we were not to be talking about all the healthcare policy convulsions today, but thinking 10 years from now, 20 years from now, what does that system look like as you see it?
First of all, thank you for having me here. The title of the conference is Inventing the Future of Healthcare.
So it's an entirely appropriate question.
If I was titling the conference, I would actually call it something different. I would call it Healthcare Next. Let me explain what I mean by that. If you look industry by industry over the last 10 years, you've seen fundamental transformation. The travel industry going to online, the retail industry moving from bricks and mortars and the mall being everything to going online and technology enabled. The banking industry, how many of you in the last year have gone inside a branch? Probably it's a small number. Fundamental transformations. I would argue that healthcare is now on the cusp of beginning that fundamental transformation. I don't think it'll be as fast as the other industries because of you may have to have more of a demographic shift towards the millennials. But when we look at we have 220,000 people, average age 27 years old. So
let me stop. So you said you're on the cusp of transition, and yet you have a lot of people in this room that are engaged in that industry. So where will they be as that transition proceeds?
I think they'll see the beginning of it. May not see the completion of it. And let me explain what I mean by that. A lot of this is going to have to do with the patient, the consumer, how they want to interact with the providers, interact with the payers, interact with the government, how they view their healthcare information, their data. And you saw it in the last two panels. There are significant differences in the answers to those questions. Now, if you start to break that down by demographics, either by age or by socioeconomic, you start to see some trends.
So pretend I'm a millennial. What do I want?
If you're a millennial, you want to be empowered.
I just want to be clear that I want to be a millennial.
Don't we all? There's certain things you want. You want to have control. You want self-service. You want to decide when, where, and how you interact with the whole eco chain. You want to be able to get information on your own so you can be an informed consumer. Now, that'll differ a little bit by socioeconomic and education, but generally that's what we see with millennials. They're less concerned about the one-to-one relationship. So we rolled out in our company eHealth, where you can schedule online an appointment with a doctor. Within a 30-minute window, you can decide how much information you put in that health information record. And we looked at usage. The usage among the millennials was off the charts.
Wow.
The usage among the 40 to 55-year-olds was far more modest. And we went and did a lot of interviews. Why are you using this or why are you not? And the millennials said, I love this. Yes, it's a different doctor every time, but I'm in control. Versus the 40 and 50-year-olds said, wait, I want that personal relationship with the doctor. So there's a mindset change that's happening. And the difference is...
What do you use?
I am more towards, I like the individual relationship, but I'm an outlier. My kids both are just the opposite. So it's changing quickly. And it has huge ramifications in my mind, both for how is healthcare delivered, implications to what is the role of a payer, certainly implications to how do you educate and interact with the consumer. And it creates tremendous opportunities in our mind for those in that whole ecosystem that get out in front of it. Now, the challenge is it's not going to happen overnight. And you've seen many failed initiatives, the Google initiative, the Microsoft initiative. Those long-term are the right thing. Clearly we're seeing that, but how far ahead of the trend do you get? Because it's going to be an evolution.
And you have you've got access to massive amounts of data, electronic health records. You're working with these systems. And I guess, a couple weeks ago we did a forum. I had Esther Dyson and some other people looking at what data could do in transforming the health system. We were a little bit more focused on patients at that session. And I said, will more data make us happy? And I guess my question is, will more data make a healthcare provider more happy or an insurer more happy? Or does it just create a lot of problems?
Sure.
Can awareness be bad?
So let me give you a couple of statistics. 150 million Americans use our administrative platforms today. So
that's half the country.
Half the country is on go through our platforms.
That's like almost every adult in the country.
Yes. A quarter of all providers go through our data exchanges. I have a little over 50,000 people servicing the healthcare industry.
So why is it so screwed up if you control so much of the market?
No, we don't necessarily control the data,
okay.
but we have insight to what all those parties are thinking. Because a lot of places, to be clear, we don't control the data. But when we think about what is the art of the possible with this information, you can start with, when you go into, let's paint the picture. You go into a physician's office, right? You fill out that 3-page form, putting everything from your social security number on a piece of paper, and every time you go to a different doctor and get referred, you do it again and again. It drives you nuts as the consumer. Mistakes are made. People don't always tell the truth on what they're putting there. You think about the provider, they now have all this paper.
Right.
I'm not quite sure what they do with it. Maybe some put it into the medical record. Most sitting in the file cabinets in the back. So you have all these silos of information. Now the payers are a bit better. They're further ahead where there is better data sharing and
they've been paying and
interaction.
monitoring and looking for.
But when you look at the provider side, the silos of data that exist are mind-boggling, and as a result, it impacts quality of care. Because more mistakes are made because you don't see the whole continuum of care for that individual. You're starting to see it with health information exchanges within provider systems where you're now starting to share information, but certainly not outside that system. So ultimately, how should...
So why is it that way? Why doesn't water run downhill? If there's so many net benefits to that data being shared and portable, why is portability so tough on the provider side?
So historically, there were technical issues. There weren't common data sets, and that's a big issue. There were competitive issues of, I don't know if I want to share that data outside my hospital chain because I want to control the patient, or the doc herself or himself don't want to share it. That's starting to change. But then you have the consumer also. Do I want everyone in the healthcare system to know I'm taking medication X? Maybe not. So we're firm believers over time it's going to be a patient information record controlled by that patient who's going to decide who gets access to it rather than, because if the patient in the end doesn't have control over his or her medical record, you're going to continue to see a lot of resistance. But I think that's starting to change. But until recently, the standards weren't there. Now the government's pushed hard on that in terms of both pushing EMRs into the doctor's offices and getting some standards for that. So technically, it's now right on the cusp of being feasible to really have interoperability across delivery channels. That wasn't true even 3-4 years ago. So now you have the hurdles of the patient, the provider. Generally, I think the payers are supportive of it, but it's there are a lot of interest there. But it's the reason I say we're on the cusp now, it's technology feasible, which it wasn't a few years ago.
So let me ask you a question that maybe will get you into trouble. Were you a player in the Affordable Care Act process?
We did a lot of activities with the payers getting them ready for it.
Supportive, unsupportive?
We were supportive of it.
So the question I have is, do you believe that a platform, because one of the interesting things you talked about is sort of an individual who might not want disclosure of something he or she was getting by way of treatment. I had a lot of friends in the sort of HIV/AIDS world who, if that were known, the social consequences and echo effects could be enormous over time. And so I completely got the privacy dimensions at that time. Are we beyond that substantially enough that the kind of pre-existing condition debate is now a done debate, and that now you can actually have less fear of consequence of that? Because that's one of the fundamental drivers of the trust question when it comes to data and privacy.
So there's still trust issues. Generally, let's come at a couple levels. Generally, a patient is not going to trust the payer to give them good advice. Because the patient, no matter how great the payer is, the patient's going to assume that payer is just trying to control costs. Patient generally will trust the provider more, but still concerned about information.
Right.
Now, personally, I think over time what will happen is certainly millennials are more open to sharing information.
Yeah.
I think incentives will be put in place, just like you're starting to see employers create incentives. Hey, I'm going to charge you less premiums if you don't smoke, or if you walk X steps a day. I think you may see some of that start to happen with information sharing. If you can be a better patient, that's going to improve outcomes, it's going to reduce costs, and therefore you should benefit from that. Now, people are just starting to experiment with this stuff, but if you get in that mindset of a millennial, they're thinking, I want to be able to make the decision, but I understand the ramifications to my decisions. And so I think we're going to start to move in that direction over time, but it's going to be a slow movement.
One of the really interesting things that's come up this morning, which I hadn't realized, was the regional differences in health system behaviors. The whole interaction, the norms and patterns are different. You live in Connecticut, right? So your doctor's in Connecticut, but you've lived here in New Jersey too, and your people that you work here, your global headquarters is here in New Jersey. Are there differences between New Jersey and Connecticut?
No,
and your data elevate these differences between regions in the United States?
I think there are less differences between New Jersey and Connecticut.
You have your U.S. headquarters in Texas.
Yep.
How's Texas?
So we're in College Station, so that's a socioeconomic.
Not really Texas.
Right.
Yeah.
It's I won't comment on that. But if I look at both health plans that we work with in rural areas where they may be the only health plan in town, right there you actually have pretty good continuum of care because they. Through the health information exchange, which is proprietary to that network. So you actually, in some ways, see better information data exchange in a smaller community than you do in New York, because here it's not a single area. Right. Then you go to places that are socioeconomic disadvantaged, and you run into a whole bunch of different issues where the patients, obviously, you have a lot more health conditions. It's much tougher to educate. We're doing something interesting right now. Someone had mentioned, I forget if it was you or someone mentioned Fitbits earlier.
Yeah.
We're doing with...
Mine's a jawbone today, but I wear Fitbit on Thursdays.
We're doing a project right now with one of the big insurers where people with diabetes, we've given Fitbits to, as well as through the Internet of Things and monitoring their glucose monitors, so seeing all the devices they interact with, and therefore being able to proactively, with nurses, call and say, hey, I see you didn't do this today. Is there something wrong?
So coaching.
So it's proactive coaching, as well as looking at are you being active, are you not being active, including sending people out if they're not. We've seen a significant improvement in outcomes as a result. Because people needed that prodding, people knew they were being watched a bit. Now, we created some financial incentives for the people to participate in the program, but it was a net win to that payer, because even after those incentives, the cost of care for that population, we're only about a year into it right now, but already...
That's a fascinating journey that you can go to. I'm staying in the, I don't know if anybody's over the Element Harrison Hotel, and you walk in and there's this big board up on a partnership that the hotel has with Fitbit, and that all around the world you can go sign up, and they have little goodies they give you if you do certain things. And I love my airline points. I might like my Fitbit points. I'm not sure yet. But when you get into that arena, I'm a sort of different person than, say, in Baton Rouge, Louisiana, where raging obesity is the norm, and you have fundamentally different problems. Literacy, particularly health literacy, is big. Do you see a way, you're so big that the kind of show and tell of good models that you see out there from the data you're reading can be transported into the places where it's most needed, which are usually low-resourced, impoverished, not a lot of economic investment necessarily, but that's part of the big ball and chain around the U.S. healthcare system, is reaching the people. I'm easy, but there are a lot of people that need this kind of attention that are not able to get it.
Yeah, so I think the answer differs by region. So in a region that's socioeconomic disadvantage, getting to the patient is probably being more important than in New York, where you have to kind of fix the system and have the continuum of care. So, so there, if you go down to a socioeconomic disadvantaged area, creating financial incentives in terms of how much their copays are to join smoking cessation programs. doing things like Fitbits on obesity, so people can need more product. And we've seen that, and that's fine. So, but I think you're hitting on an important point, Steve. There's there's some fundamental things that have to happen across the country, particularly around exchange of EMRs and the continuum of care. But what you then do with that is going to differ by region, and differ fairly significantly by region.
You also say in your sort of bio about that you help promote innovation within healthcare systems. What does that look like? Because sometimes innovation in this space is, to say it mildly, is among the most controversial things you can do, because it involves, pay lines, jobs, the way we used to do things.
So let me give you a couple examples, things we're really quite proud of. We were challenged by an overseas hospital that they want to reduce the cost of cardiac care episode by 30% and improve the outcomes by 40%. And we went in there and looked at how they were doing things today. And we turned and this was a big hospital. We turned that cardiac care completely paperless. So, and where's the inefficiency? There are 10 million alarms that are going off. The nurse has to come to each one. The doctors get called on the wrong things. So instead, enabled that all through an iPad. So the technology looked at which things needed what sort of assistance. In this country, the families were more involved in care, so it also enabled them. After 2 years of doing it, achieved both the cost and outcome benefits. It's now rolled out to the Cayman Islands, and it's coming to the U.S. soon. So an example of fundamental difference. Now, that was all driven by that hospital and those doctors. They had a goal of they wanted to be able to take cardiac care to more people, and this was the only way to do it. And it ruffled a lot of feathers that, hey, doesn't a doctor or nurse need to make that decision? And the reality was, the technology could actually make more effective decisions in certain areas and free up the doctors and nurses for the things that really took human interaction. Someone was talking about the robots earlier. In a sense, it's a little bit of that, but the data shows in this particular example, it's been extraordinarily effective.
I don't know if any of you have seen that Apple Computer is set out to make a car. Google is out basically considering the pathways to the end of death with Calico and others, which is totally interesting. It freaks out Washington because if people don't die, it creates a whole different arena for mandates. But, I guess the question I have for you is, does Cognizant one day become like that, where why would we need, excuse the comparison, but I remember when I studied the Soviet Union, the general secretary who kept the data and addresses for everybody was the most powerful in the party. Isn't the person that holds all the data the most powerful person, player in the equation, that you can eventually become the provider, that you could become the insurer? As you sort of think about the pathway of big data holders, do they become the power players in reform?
I'm not sure you can have big data. We don't hold the data. We're an enabler of moving the data around, but the data is owned by the...
Maybe you should hold it.
I don't know if that's the right answer, actually, because I think if we held it, then people would be more nervous about sharing it. The key is, when you look at the different constituents, let's start with payers, who are further down the path of getting being efficient on using technology for administration and so forth, but still huge opportunities, particularly around digital, how their members interact with the insurers to improve satisfaction, improve the timeliness of responses, all that. Tremendous opportunity there. And you're seeing across the board healthcare insurers right now investing in digital for the interaction with both with providers and with members, and easy return on investment there, improved satisfaction levels, all that kind of stuff. So that's pretty clear. I think you're seeing a lot of insurers start to question, should they be running their own back office operations, once again, to get cost out of the systems? Is there anything really proprietary about how you process that claim, or should that be more on a shared basis? But so there'll absolutely be a role for an insurer going forward. Now, what it may look like may differ a little bit, because I don't think you'll have as many call centers. I don't think you may have as many people doing the processing, because all that's going to get digitized. On the provider side, absolutely, there's a role for the provider, but I think you will. I think you will see a lot more e-health. I think you will see a lot more minute clinics. I think you will see the interoperability across all these for that common patient record, so you get a lot of efficiency just in terms of the administrative activities on the provider side. You go into a doctor's office today, right? 80% of the staff are doing administrative tasks, right? Think about how much lower the fees could be if you didn't have all that. So I think a lot of that is going to become streamlined and digitized as you have more connectivity. But there will clearly continue to be an important role. But I think the difference is where, if you go back a while ago, the power was with the insurer.
Right.
Then the power shifted to the provider. What I'm absolutely convinced about it, everything we're seeing, the power is going to shift to the consumer.
Fascinating, fascinating. Let me open up to all of you. Questions, comments before we wrap it? Yes, right up here in front. Cynthia, we're going to bring a microphone to you so that everyone in California can hear you.
Oh, you're going to hold it.
Yeah, go ahead.
Cynthia Meanwell, the
Hi, thank
Medicines
you.
Company. Very interesting. I'm very excited about the electronic health records opportunities and big data for healthcare in general. But privacy issues will remain as long as we have most of our healthcare insurance delivery through employers and the discrimination potential there. But arguably, of more concern is security, identity theft, security from medical records. So could you speak to that?
Sure.
Terrific question. Thank you.
Which do you feel more secure with? Filling out that paper form in your doctor's office, putting your social security number on it, or having a health record hosted by Google or Microsoft, who probably have the greatest security in the world? It's a change in mindset, but I would argue that, which is also encrypted, by the way. So I would argue
Except in China.
I would argue that from a security standpoint for your privacy, it'll actually improve. Here's the key, though. Who has access and control over that record? And that's important. And is that the patient, the member decides who gets to see what? Or is it the insurer that gets to decide who gets to see what? I think the answer is it'll have to be the patient, because otherwise people will be hesitant to put their information out there for some of the reasons you talked about earlier. But the cyber component of it, absolutely there is a risk, but I would argue there's far less risk in some of that being institutionalized and put in fewer places where you can have the world's greatest security rather than sitting on the server at a doctor's office or the server of a small plan somewhere. We do a lot of work in our business where a health plan had their own IT shop and so forth, and they say, come take it over, do all the hosting for us, do everything. One of the reasons why is they say, we can't keep up on the security issues locally. We can't make those investments as a small or mid-sized plan. So is there a risk? Absolutely, but I would argue the risk actually comes down compared to the very significant risk that exists today. But there will be more data out there.
And as you said, and we opened up here at the beginning, there seems to be a generational shift and a generational tilt towards more of that. I'm looking at my friend Michael Laskoff of Able2, who said that into telemedicine. I'm totally into telemedicine, but most people my age are not. Where that again, the next generation, in my desire to sort of look and feel and walk like a millennial, though it hurts, are going to be much more in that space. So I think it's a great question. I also see attitudes changing dramatically. Maybe that's a dangerous thing, and people will find from getting burned at some point the consequences of that. So we'll see. Yes, over here, right? This gentleman. Hello again. We're going to get you the microphone, yeah.
Matt Marin, Denville, New Jersey. I've heard a lot this morning about value. I've heard about quality. I've heard about outcomes. They all seem to be focused from the perspective of either insurers or hospital systems. How should we truly define outcome or quality or value?
Question.
I don't believe that process, or I'm quite sure that measuring the number of mammograms that are done this year versus last year is a way of determining value. Could you comment, or others comment on value?
Sure. Some that may be more appropriate for others on their earlier panel, but from everything that we see, I agree with you. Value is not, okay, let's just get the cost of a mammogram down $5 from what it is. It's the appropriateness of what are the procedures, and ultimately the health of the population. How can you most efficiently provide the services necessary to have a healthy population? And that goes through lots of things. Like when is it necessary to see a doctor versus a physician's assistant? When is telemedicine appropriate? When is self-service appropriate for something? Interesting statistic. There are now 22,000 applications on the iTunes Apple Store related to healthcare.
How many?
22,000. That was as of 2 months ago. It's probably up some more. But that says people want to have some impact and some say in their healthcare.
Right.
And I think you're going to see more of that. Now, what's the definition of a good outcome? That will differ by individual. The person in New York, one person may say, hey, if I don't have the correct BMI, I'm not healthy. Others that may be irrelevant. But in the end, the value-based care, it's going to happen. I think it has to happen. Consumerism is going to happen.
How do you find that soft point? It's a great question. Let me take it out of the health context for a minute. I knew the chairman and founder of AMC Theaters, and if any of you lived in Century City, California, out on the west side, there was an AMC Theaters that was the best AMC Theaters in the United States. They purposely over-serviced that theater. They wanted to create a red carpet experience, bar none. The ticket price was really low, but the point was they were experimenting with ways of delivering phenomenal service that had nothing to do with the price point of the ticket. But throughout the rest of the system, it was to basically look at how do you find that balance between the fee paid, the service given in that arena. And it sort of seems like a similar question, that how do you find the nexus in a health system between outcomes for the patient walking in, but not so over providing services that you actually undermine and upend the cost of the system and the provider, insurers, et cetera. So how do you actually negotiate that line?
That gets
because that's what you have to do if you're talking about value.
That gets well into the political arena of should it be the same line for every individual in the country, and we could debate that.
Want to have another conference on it?
But the answer is, and I think in the end it won't be the same line for lots of reasons. There are some employers who want to give Cadillac plans because of the demographics of the workforce, but for whatever, and whether it's employer or individual is paying, are they getting value for what they're paying? I think ultimately it'll be some of the way that it's measured.
If you were to do, I was astounded this morning reading about New Jersey. All of you are phenomenally healthy, way more healthy than those of us in D.C. And so very healthy. You pay a lot for your health care. You're not going to have big increases in your premiums. In fact, you may have a decrease. The New Jersey picture is sort of this unique, cool health picture, and that's why folks, I think, showed up today. But if you were to do one thing within the New Jersey context to change the game in a positive direction, what would that be?
Interoperability of data in healthcare providers. Because in New Jersey, because there's so many separate players in the system right now, you don't have that interoperability.
Ladies and gentlemen, Gordon Coburn, the president of Cognizant, thank you so much for joining us.
Thank you, Steve. Appreciate it.